Hi, I'm Marvin Natowicz. I'm staff at the Cleveland Clinic, and I'm on the faculty as professor at Case Western Reserve University School of Medicine. And we're fortunate today to have with us Dr. Greg Holmes, who is chairman of neurological science and professor of neurology and pediatrics at the University of Vermont College of Medicine. Dr. Holmes is a well-known, very esteemed clinician and researcher in the fields of neurology, especially epilepsy, and has served as past president of the American Epilepsy Society and has received numerous awards and honors from many organizations for his clinical work and for his research. Today, Dr. Holmes will be talking to us about autism and epilepsy. There are several learning objectives for today's session. First, we'll review some important clinical issues relating to persons having autism and epilepsy. Second, we'll have discussion relating to selected important aspects of etiologies and pathogenesis of epilepsy in persons with autism. And third, we'll have Dr. Holmes speak to us about important gaps in our clinical understanding and treatment and in basic research understanding relating to autism and epilepsy. Thanks very much for being here. To begin with, Dr. Holmes, can you explain to the viewers how autism is defined and how the diagnosis of autism is currently made?
Yes, autism is really a spectrum disorder, and the major problem the children have or the adults have are problems with social communication. And they also have difficulties with repetitive, fixed behaviors that we call stereotypic behaviors.
Mm-hmm. And in making the diagnosis of autism or in screening for autism, what are some of the strengths and limitations of the approaches that are currently used?
I think there are quite a few strengths, actually. So there have been a number of scales developed that can be administered by pediatricians in their offices. And these are pretty well documented scales that can be, you can use to evaluate the children at 18 months, 36 months. So they're checklists. They can be done by pediatricians fairly quickly, 5-10 minutes, and they can get an idea whether the child has autism at that point. So a lot of it is based on the history, that you can take the history from the parents, and then you can also observe the child in the office. And again, there are a number of scales that different people use, but they're very quick and accurate, and the diagnosis can be made much earlier now than it used to be in the older days. Mm-hmm. The weakness is that we do not have a biological marker for autism. So it's really based on observation. The child, as I mentioned before, has major difficulties with communication, social interactions, and those are keys. And by asking the parents a few simple questions about imaginary play, does your child point to objects? If you call the child's name, do they respond? These type of questions are very easy to answer by most parents, can be quite helpful in making the diagnosis. Parents often ask me, is there a blood test I can do to make the diagnosis of autism? No, it's really a clinical diagnosis at this point. We're going to talk a little bit later about the etiology and the causes of autism, and there are certainly tests you can do there, but as far as the clinical diagnosis, it's primarily based on the history and clinical observation.
Are there certain clinical conditions that might affect a child or an adult who has autism or who is thought to possibly have autism that might complicate the clinical ability to be sure of the diagnosis, such as perhaps severe cognitive impairment or epilepsy? Could any of those confound or make it more complicated?
Definitely, yes. It's the child with your more typical autism, I think, is a little easier to make the diagnosis than children with a developmental delay. The children with developmental delay are often delayed in language skills to begin with, and language is a very important part in diagnosing autism. So I think a child that has significant developmental delay Whether they have autism or not, I think is much more difficult to define. And it does make research into autism and treatment a little more difficult as well, because you have these, it's a spectrum where you have very high functioning children that have autism versus those children that can be pretty profoundly impaired that also have the characteristic features of autism. It's important to say that not all children with developmental delay, for example, have autism, but it is a little more complicated in the children with developmental delay, teasing out the autistic features from their other features of their developmental delay.
And in terms of the topic of epilepsy, how do you as a specialist in that area of medicine define epilepsy, and how do you and others in your area of expertise categorize and characterize the epilepsies?
Yes, epilepsy is defined as 2 or more seizures that are not provoked. So, you know, many children will have febrile seizures, for example, and the seizures are provoked by fever. And once they get a little older, they no longer have seizures with the fever. Those children, even if they've had multiple febrile seizures, they're not considered to have epilepsy. But if you have more than one seizure that is not provoked, then that is defined as having epilepsy. Yeah, so some investigators also define epilepsy as one seizure as long as you have some other collaborating evidence that the patient is going to go on to have more seizures. For example, a child with tuberous sclerosis, when they first present to you, may have had one seizure, but we know with tuberous sclerosis that the likelihood of them going on to develop other seizures is very high, and so we would classify them as having epilepsy at that point.
Mm-hmm. And how do you categorize or differentiate the different types of seizure disorders or epilepsy disorders?
Yes, it's also similar to making the diagnosis of autism, in that we rely quite a bit on the history from the parents or the patient or someone that accompanies the patient to clinic. It's based on the history, and you have to give a behavior that sounds like a seizure. Now, seizures can vary from really events that are clear-cut to anyone walking down the street. If someone has a generalized tonic-clonic seizure or convulsion, used to be termed grand mal seizures, it's very clear they fall to the ground, they jerk, they have saliva, become very stiff, and following the seizure they have postictal confusion. But other seizures are much more subtle. In children we often see absence seizures, used to be called petit mal seizures, where they will simply stare, often a little bit of eye blinking, and those last 10 to 15 seconds. And then you can have another type of seizure called focal seizures with altered awareness, used to be, another term for that is temporal lobe epilepsy. And these are patients that can become confused, disoriented, have automatic behaviors such as lip smacking, mumbling, fidgeting with their hands. These can usually last a couple minutes and then are followed by some degree of fatigue and tiredness. So you start with a clinical history that sounds to the clinician like a seizure. And at that point, you then go on to diagnostic testing, and still the strongest test we have now is the EEG to help you confirm that diagnosis.
And do you use the EEG as part of your classification or categorization of epilepsies?
Yes, and you always use the EEG in conjunction with the clinical history, which is so important. So basically the broad breakdown of seizures are focal seizures, which begin in one part of the brain and may or may not spread and become generalized. And the other classification is generalized seizures, where the seizures involve bilateral brain structures from the very onset. Often in focal seizures, when you do an EEG, you'll see spikes or sharp waves coming from one region of the brain. And in generalized seizures, you'll see generalized spike and wave discharges. The classic example is absence seizures, where you'll see this 3 per second spike and wave discharge on the EEG, which anyone who's ever looked at an EEG, you can spot it from across the room. It's very, very obvious because it involves all areas of the brain from the very onset. Whereas focal seizures may have much more subtle EEG findings, and this, the focus tends to be, you may have temporal lobe spikes or frontal lobe spikes, but the spikes arise from the area of the brain where the seizure is beginning typically. So the EEG is very helpful to you. It's not an exact science. Sometimes you'll look at an EEG and it'll look like generalized discharge, but it really is a focal discharge that quickly spreads. And so those patients would really have focal seizures with secondary generalization. But the EEG is quite important and helpful. But again, always used in conjunction with the clinical history.
And how often are seizures and how often is epilepsy present in children and in adults with autism? And are there particular types of epilepsy that are seen more commonly?
Yes, that's a very good question. You know, if you go back and look at the very early writings by Kanner on autism, he noted in some of the original patients that they had epilepsy as well. And over the years, we found that this relationship is much higher than we had initially expected. And it's really been, I think, very helpful as we get further into this conversation as far as talking and trying to understand the physiology of autism and epilepsy, the common bonds they have between the two conditions. But the bottom line is that the risk of epilepsy in autism is significantly higher than the normal population. The studies vary quite a bit, and the children that have, and adults that have autism and intellectual disabilities or developmental delay have a risk of epilepsy of around 25 to 30%. If you look at children with your classical autism, the risk is only about 10%, but that's still much higher than the normal population. Just like in the normal population, the types of seizures the children have and the adults have with autism are varied. They can have various seizure types, especially those with the associated with developmental delay. But typically they are more focal seizures, and they also tend to be more in the coming from the frontal or the temporal lobe of the brain in the children with autism and the adults with autism.
And do you see, or do persons in your specialties tend to see increased likelihood of seizures in particular age groups of persons with autism?
Yes, it somewhat varies on the etiology of the condition. But for example, in tuberous sclerosis, we see children that have a very tuberous sclerosis is associated with a very severe seizure syndrome called infantile spasms. And in infantile spasms, the children with tuberous sclerosis and infantile spasms have a very high rate of going on to have autism. So we see an early group of children that have autism and develop seizures often before the age of 6. And then you have an older age group, so that in the mid-teenage years, there's another peak where individuals with autism can develop epilepsy. Unfortunately, there's no time stoppage. You can, if you have autism, you can have seizures at virtually any time of your life, although most of them begin at least before young adulthood. So it's a little unusual for us to see them develop in the older population. But so young group, and then more the mid-teenager group, and somewhat dependent upon etiology as well.
And are there persons with autism who do not meet the criteria that you just mentioned for having epilepsy, unprovoked seizure disorder, but who have a consistent or relatively consistent abnormality of EEG tracings?
Yes, that's another really good question. There are a very high percentage of children and adults with autism will have an abnormal EEG. And if you look at the data, it's quite striking as how far is in regards to how many have EEG abnormalities. So some of the best normative studies come from a group of children in Sweden where they looked for interictal spikes on their EEG, which is a marker for seizures. And it's about 1%, 1.5% of the normal population. If you look at children and adults with autism, some studies have shown up to 60% will have abnormal epileptiform or spikes or sharp waves on their EEG. Now, part of this is due to how the EEG is done. We and most institutions now are tending to do more longer recordings. So if you do an overnight recording on a child with autism, you're more likely to find an abnormality than if you do a typical 30-minute EEG. So I think that explains some of the discrepancies in the literature about the frequency of the spikes. I think it also is important to note that, again, whether the child has more typical autism or has autism with developmental delay or intellectual disability, those children in the latter group tend to have more abnormalities on their EEG as well. The EEG is somewhat tricky, and you have to, and I always like to revert back to the clinical history, so that certainly not every child that has autism and has an abnormal EEG has epilepsy. So you have to always take the clinical history in account if you do it, but you do tend to see more EEG abnormalities. And as I mentioned, I think earlier, the interesting thing is that the frontal lobe in particular tends to be a real focus in the children with autism, and may have something to do with the pathophysiology of autism as well.
And you mentioned you also see a certain percentage, I think you said around 1% or so, of abnormal EEG tracings in the normal population. In persons who are normal who have abnormal EEG tracings, or persons with autism who have abnormal EEG tracings, can there be any clinical correlates?
There may not be any clinical correlates at all. If you have an abnormal EEG, again, it doesn't mean that you have seizures. Now, it turns out if you look at children, even in that normal population that was studied in Sweden, if you have an interictal spike on your EEG, say you're that 1% of patients that have that, a small percentage of those patients did go on to develop seizures. And I would say probably the most likely thing is in autism too. If you have a spike on your EEG, you're still more likely to have seizures in the future. But that would, from a clinical standpoint, we would not put those children on medication. We would go back to our definition that you have to have at least one seizure in an abnormal EEG or 2 unprovoked seizures, depending on which definition you use. So we do not like to put children on medications or adults on medications just based on the EEG abnormality in the absence of really solid clinical findings.
And are there certain groups of persons with autism who are more likely to develop seizure disorders? You mentioned tuberous sclerosis. Are there other categories, pathophysiologic categories of conditions where a person with autism is likely to have epilepsy more than the general population?
Yes, there are a number of genetic conditions. I think tuberous sclerosis is one that stands out. There are a number of others, such as Rett syndrome, for example. Angelman syndrome is another example, where the risk of epilepsy is significantly higher than the risk of having the autism. So those are children that are really at high risk for developing epilepsy. And there's both, for example, Down syndrome is another group, the chromosome abnormality that can lead to autism and much more likely than would be expected in that population as a whole. So those patients would be at very high risk.
And in those persons who have a genetic liability to developing both the autism and the epilepsy, does that tell you something about the biology of the underlying brain biology and a connection between the autism and the epilepsy, or is that difficult to take apart?
I think it's a great question. I think it's really important to look at that group of the patients, because you know, the epilepsy is really a disorder in which excitation and inhibition in the brain is imbalanced. So our brain is always sort of this nice balance between excitation and inhibition is occurring all the time. And if you have too much excitation in the brain, that can lead to seizures. Interestingly, in epilepsy, if you have too much inhibition, that can actually lead to seizures, because sometimes increased inhibition through GABA, which is an inhibitory neurotransmitter, actually leads to increased synchronization of electrical discharges. We also think of autism too now as a problem of neuronal networks, different areas of the brain talking to other areas. And there's increasing evidence that in autism there's increased excitability as well, and that this increased excitability may lead to increased connections between different parts of the brain that are the brain is almost overwired and hypersynchronous. And so that whether the child has a seizure or whether they have the difficulties with the social awareness, interaction, both may be related to this imbalance between excitation and inhibition. So we're looking more and more as we think about epilepsy and autism, thinking more and more about the networks that are involved. Both are complex disorders, and that we know that this is not due to just a single group of neurons. It's how the brain areas talk to one another, and they may be linked together. And I think that's why it's very important for individuals that deal with epilepsy and individuals that deal with autism, physicians and scientists talk to one another, because I think there's some common links there that may not provide all the answers, but I think it's certainly worth pursuing at this point.
Dr. Holmes, thank you so much for presenting your experience, your expertise in these important clinical issues. This will be a tremendous benefit to the viewers in their care of children with autism and epilepsy. We're very grateful for having the opportunity to spend time with you.
All right, thank you.